Welcome, everybody. My name is Marie Gerson, and I lead our global education and practice solutions with Schein Orthodontics. We're moving into here now from Dr. Francisco Eraso, who is an orthodontist and radiologist from Indianapolis. And today he's going to share with us comprehensive treatments with minimum touch technologies and appliances, a clinical and radiographic perspective. I'll introduce Dr. Eraso now. He's an orthodontist and oral and maxillofacial radiologist. He has his DDS from Pontificia Universidad Javeriana, Bogota, Colombia. His advanced dental degree from Indiana University School of Dentistry. He has his MS in oral biology from University of Louisville. His certificate and MS in oral and maxillofacial radiology from University of North Carolina at Chapel Hill. His orthodontic certificate and MSD from Indiana University. He's a reviewer for the American Journal of Orthodontics in dental facial orthopedics, angle orthodontics, the Journal of Oral Surgery, oral medicine, oral pathology, oral radiology and endodontics, and the Journal of Dental Maxillofacial Radiology. His credentials are amazing. Published numerous papers and lectures at professional meetings and CE courses globally. He's a member of professional societies, including the American Dental Association, American Association of Orthodontists, American Academy of Oral and Maxillofacial Radiology, and International Association of Dental Maxillofacial Radiology. Please join me in welcoming Dr. Francisco Eraso for comprehensive treatments with minimum touch technologies and appliances, a clinical and radiographic perspective. Thank you.
Greetings from Indianapolis, Indiana. My name is Francisco Eraso, like Mary introduced me. My goal is to give you a lecture or presentation about comprehensive treatments with minimal touch technology and appliances, and a clinical radiographic perspective. The clinical and radiographic perspective is because I'm a dual trained radiologist and an orthodontist, and I'm one of the few that spend all the time doing radiology and all the time doing orthodontics. How can I do that? It's because I enjoy everything that I do, and I have so much fun reading X-rays, doing diagnosis, seeing my patients. I think orthodontics is my hobby. I lecture internationally and nationally, and also I'm a part-time instructor at Indiana University. I'm going to give you what I believe is going to be some kind of like introduction of what inspired me, and I hope I inspire you. You know that orthodontics is more about than teeth. You know that the orthodontics, we have the ability, in orthodontics, we have the ability to influence the face, but also the skeletal and dental structures. We have the ability to provide quality results influencing all of the structures in the maxillofacial complex. Over time, there have been people that inspire me a lot, and I'm not trying to kiss ass, but Dr. Carrier is one of those persons, or the person that inspired me from the moment that I saw his first presentation that I went. It was in Orlando at the AO, and when I went to his presentation, he gave me the tools that I was looking over time to not only make dental changes, but transform people's faces and lives. One of the cases that he presented, and I have access to that case today, was this. What happened if the patient walked into your office? How you treat this patient? This is a 29-year-old female patient, retrognatic mandible. It has very difficult to close her lips, very difficult to have a beautiful smile. And she was looking for a solution. She was looking for a transformation. So she looked for Dr. Carrier. Dr. Carrier offered the solution that he believed transformed the patient's, not only the dentition, but also the structure, the surrounding maxillofacial structure. This is a 29-year-old that I think is a very complex case, is a very unpredictable treatment, and in my opinion, is a very difficult case. Because of the extractions of the second, or the, I'm sorry, for the mandibular bicuspids, it makes this case a little more difficult. If you have a second opinion consultation, a lot of people will choose orthodontic surgery. How about if we extract maxillary bicuspids, make the case worse, and then we improve everything with orthodontic surgery? That was something that the patient didn't want to do, okay? So Dr. Carrier said, okay, we can solve this in the way that he does the best, using the motion appliance. Minimum touch technology, minimum appliances, minimum touch appliances. He uses a very aesthetic appliance, which is the Motion Clear Class 2. And he used that for 3 months. He provided a comprehensive care delivered with predictable, relatively easy approach. And the reason why I say easy approach is because everything that he predicted using diagnosis and treatment planning happened in this case. Canines are in class 1 relationship. They develop the spaces to correct the overjet. He rotates the mandible forward to change the profile and the aesthetics of the patient, giving phenomenal results. So let's see the results from the beginning to the end. What happened with this? This is a standard and the way that Dr. Carrier simplified complex cases. In 11 months total treatment time, he was able to transform this patient's life, and that is something that I want to do. So I use the motivation and the inspiration of other people's work in my job. For example, I read maybe 6,000, 7,000 X-rays. I do diagnosis and treatment planning for a lot of people. I treat my patients, and sometimes I use inspiration. This case was that inspiration. How can I transform the patient, giving solutions like this in short period of time, from the beginning to the end, spending literally 11 months, 3 months for correcting the sagittal relationship, correcting the profile. Look at the change and the rotation of the mandible, correcting the aesthetics of that patient, the aesthetics of the profile. And at the end, the patient have a very unbelievable results. 11 months is the total treatment time. Skeletally, of course, I am a radiologist, so I'm going to look the X-rays. Unfortunately, it's very difficult to measure the impact of the airway spaces with 2D X-rays, but definitely because of the rotation of the mandible, the reposition of the hyoid bone and the tongue, definitely the patient has an impact not only in the airways, but in the facial profile. In that lecture, also, Dr. Carrier inspired me to say, okay, you know something, I can not only correct class 2 or class 3, but also I can apply this technology to also kind of treat class 1 patients, very crowded patients that we're really trying to avoid distractions, and how we can create those spaces without, you know, doing something that we don't want to do. So that was an inspiration. That was my inspiration. My story is a little different. My story, in addition to the inspiration and all of the lectures that I've been attending, not necessarily giving, but in my story, I've been learning by observation, a lot of observation over the years. And one of the things that happened in my story is when I went after I finished oral and maxillofacial radiology in 1998, I am maybe 22 years already a radiologist. So I went to do orthodontics. When I did orthodontics, I didn't have any experience in orthodontics. Literally, I never placed a bracket, I never placed a band. The only tool that I had was my diagnostic knowledge. And the way that we approach the cases in our residency, and most of the people today, is they take records, photographs, they take 2D X-rays, panoramic and lateral ceph, measure in the way that we know how to do it, doing the cephalometric tracings. And we pretend that with only that information, we are going to treat the patient's mouth. The problem with that approach is that sometimes what we don't see is what we don't know, okay? So in this case, this is a very constricted maxilla, open bite, class 2 canine relationship. It has some skeletal relationships, but that is the only thing that I can see in that case. The problem with that approach is I'm going to maybe miss something in the temporomandibular joint. For example, in this case, when you have an open bite, you don't know if that open bite is because of a habit, tongue position, or maybe thumb sucking, or because of something that is happening in the temporomandibular joint. So very difficult to say. In my opinion, this case has an airway issue, an airway problem. So from these records, we are not going to be able to see that. So when you have a partial diagnosis, you're going to have a partial treatment. In my opinion, I didn't treat this case. I was trying to correct the habit. I transferred the case to the next resident, and the next resident, I don't know what happened. So that is how I learned. Like, okay, then if I'm going to treat the case, I need good records. The second observation or second inspiration that I have is this. When I read the Graeber book, okay, Graeber was telling us that orthodontists are champions in giving or in acquiring data information, diagnostic information. The problem with acquiring this information is that we are segmenting maxillofacial structures in 2D pictures. So if it's an adult patient, we are going to have order periapical full mouth series. Sometimes we order a panoramic radiograph. The panoramic radiograph, the American Board of Orthodontics used it to measure root parallelism because of all of the distortions and magnifications. I think it's not a tool for that. So in my opinion, it's a good tool to count teeth, to determine impactions and presence or absence of teeth. But that's it. After that, we take photographs because we have to document the case very well. And in addition to that, we are taking 2D X-rays, lateral ceph, posterior anterior radiographs. We trace them. We sometimes take pictures of the TMJ. Only until today, people are taking tomograms, and you are be able to see not only the temporal bone, but the mandible, the condyle of the mandible, and the position of the condyle of the glenoid fossa. But before, because of the lack of the 3D ability to see the TMJ, we saw pictures like the submental vertical view, the transcranial picture that literally don't show anything. And we pretend to do diagnosis with these cases. The problem with that is we are giving the patients 2D diagnosis with all of this information. So we acquire this massive amount of information, thinking that we are doing diagnosis the right way, in my opinion, my personal opinion, and we are providing 2D information. So I learned from observation. So the second way of inspiration is when I analyze information. It's very easy to criticize something, okay? It's very easy to pick mistakes that somebody did in a treatment plan. So in the program, in the residency, all of these records are from my residency. This case was a case that was treated in 1998. I started my residency in 2002. The patient was treated for 4 years. So we are analyzing the case, the length of the treatment, the quality of the treatment, the retention of the treatment, and the impact in the dentition and the maxillofacial structures. We learn from observation. We criticize things that we see in those cases. This is a late mixed dentition case, very high angle or very vertical sensitive case, and we see a beautiful face. It's a class 2 molar relationship. So how we are going to treat this case? Look at the key in this case. The only thing that we see in this case is the class 2 relationship, or in my opinion, that is the only C that the resident saw in this case. How I'm going to correct the class 2 relationship? Forgetting about the temporomandibular joint, forgetting about the airway structures, okay? So the reason why they don't see that is because they never have the tools. They have all of this information that is not showing as much as we need to see. So 4 years later, we have decent result. Decent result is because according to the American Board of Orthodontics, this case is not necessarily the best case. After 4 years, we have a straight teeth. We have a class 1 relationship because we use a herbs appliance for a long time. However, the patient is lacking of this mutually protective occlusion, meaning it has the tendency to have an open bite. Midlines are okay, still we have some spaces. And as you can see, there is some marginal ridge discrepancy and some spaces. Literally, there is spaces all over. And when the patient bite, I don't think the patient is stable. The problem with an unstable occlusion is that the occlusion protects the TMJ and the TMJ protects the occlusion. If that doesn't happen, something is going to fail, okay? So this is the X-ray, the panoramic X-ray for the V records, meaning for the after the treatment. The other thing that we see is this. The longer that we do treatment is not necessarily we're going to have better results. And we have proved that in a lot of research that we have done. I'm going to show you the citations that we did in Indiana University. So the longer the treatment doesn't mean that we're going to have better results. The problem with this case is, in addition that we have longer treatment, I don't know if the patient has root resorption and blunting for all of her teeth because of the treatment or because of genetic predisposition of this patient. Because I did my research about genetic predisposition, about root resorption, and we did a lot of research about that in Indiana University. So this case has a combination of that, maybe genetic predisposition, maybe too long, maybe the biomechanics was too much for her, and we spent 4 years doing the treatment. In addition to that, when we see this X-ray, we only see teeth. However, when we go and see on the side, we see changes in the temporomandibular joint, okay? Okay, see what happened. The patient is vertically sensitive. The patient grew in the wrong direction. Usually the patient grew down and forward. This patient grew down and back, okay? So when that happens, the patient will have a tendency to have an open bite. In combination with temporomandibular disorders, the result is going to be an open bite, okay? A record, B record, 4 years, and 2 years later when I was in the residency, now I see the case, okay? Now I see the case after 2 years of retention. The face, in my opinion, was not necessarily the best. We start with a very nice, beautiful face, and then because of the patient's growth and the changes in the maxillofacial complex, it affects the patient's aesthetics, in my opinion. Second thing that happened, the patient grew in the wrong direction, as is showing here in the superimposition and regionals. So the patient grew down and back, okay? Of course, you see the correction of the class 2 relationship by the headgear effect using the Herbst appliance, but the combination of everything together is not, in my opinion, a good result. Remember, it's very easy to criticize, it's very easy to pick mistakes, but the inspiration from Dr. Carrier plus the observations that I have done over the years is telling me that we can do better. Minimum touch technology and appliances. That is what we're shooting for today, where we want to have cases that we use minimal appliances, minimal time, and we have unbelievable results. That is what we're shooting for. Taking into account all of this, anatomy is anatomy. Diagnosis is diagnosis. Treatment plan is extremely important. So the minimum touch technology doesn't mean that we should not do all of those things. Actually, we should use all of the technology for our benefit so we can maximize that minimum touch technology and appliances. This is the C record. You see again, now you're going to start to see the open bite and then the final result with the C records. This is, I don't know if you want to take a screenshot, but these are the references that are telling me that the longer the treatment, not necessarily the best results. And doesn't matter how difficult is the case or the sex or the complexity of the malocclusion, the outcomes are not necessarily better when we spend more time doing the treatment. So it is extremely important that we know that. We did the publications at Indiana University with all of the residents and the students as the thesis projects, and this is the result. So the inspiration is this: the best results start with adequate and complete diagnosis. Inspiration to do the best from Dr. Carrier, observations that what happened here, and That will only lead me that this is my mantra. The best results start with adequate and complete diagnosis. Diagnosis is the foundation of our cases. Without a correct, a proper diagnosis, we are not going to be successful in our treatment plans. This is the way that I do a treatment plan in my office and how I approach my patients in my practice. So I connect with the patient. The clinical examination is minimal, but the reason why the clinical examination is extremely important is because the patient goes to our office, okay, with one thing in mind. I want to get treated. I want the patient to give me an answer. I don't want to be, oh, let me think about it. I don't know how to do it. Let me read the books. No, that is not the answer that the patients expect. So during the clinical examination, we know exactly what we are going to do. Sometimes we start the patient right away. Sometimes we have the ability to start the patient in the same appointment. A lot of people do that. However, in the clinical examination, we acquire the records and the diagnostic information that we need to do our homework to see if we miss something in the clinical examination, the first appointment. So we take digital information such as photograph, CBCT, and intraoral scan. See that I say digital information. Most of the information that I have today in my practice is digital. I don't take impressions anymore. I don't take 2D X-rays anymore. I take 3D combined computer tomographic images. And then when I have that information, I do my homework. I do my radiology reports. And the radiology report is extremely important because sometimes I subtract all of the information that I have from the combined computer tomographic images. And sometimes I rethink things. Oh, maybe I missed something in the clinical examination. So I create a nice report so I can discuss that with the patients or the patient's parents. I sometimes, not all the time, to be honest with you, I create anatomic models from the combine, and I create image portfolios. Image portfolios is no more than an album of pictures. And this album of pictures is going to help me to remember how we start, how it went, how is retained. And then I make the decision. The patient maybe start the treatment before, but in this second appointment, I discuss with the patient if I have any changes. I give a copy of the reports, a copy of the pictures, and definitely I embrace the decision. So I start treatments at that appointment with braces, aligners, or maybe I can band the motion appliance or start a comprehensive treatment plan. Okay, so that is the sequence in my practice. So this is the digital flow work. Okay, clinical photographs, combined CT, and intraoral scan is for every patient. It's no exception. If a patient comes after all of this discussion, if a patient comes to my practice and says, I don't want to take a combine because of radiation dose, of course, I'm going to explain why it is not a concern. But if the patient still don't want to have a combine, definitely I don't do a treatment. Because if something happened and I don't have that information, I cannot discuss that information in court. The first question that the lawyer is going to ask me is, where is your combined computer tomographic image? Because we see a problem here. And not only that, I want to have the best diagnosis, because remember, diagnosis is the foundation of my treatments. If I don't do that, I'm not going to have good luck and good treatment plans and good and more predictable results. I cannot shoot for minimum touch technology and treatment plans and appliances because I missed something maybe. So this is extremely important. When I have the diagnostic information, we have something that is called the diagnostic key. And the diagnostic key is extremely important. The diagnostic key, again, you know, and I preached this for a long time before I met Dr. Carrier. And I talk about the diagnostic key. There's 3 structures in orthodontics that I have to have green light: airways, TMJ, and dentition. I have to be able to see those structures very well and see what's happening and how I'm going to impact those structures in my treatment before I start the treatment. So airways, TMJ, and dentition. Dentition, no more than teeth, but also the dentition support, the alveolar bone. Sometimes we have a lot of crowding and minimal support alveolar bone support for the anterior dentition. And it's it's red flags that we have to be able to see before we start. This diagnostic key is extremely important for me as a diagnostician, as a radiologist, as an orthodontist. However, I was extremely inspired again in this lecture when I see this video. And again, the motion appliance, the class 2 motion appliance, will have effect in the soft tissue, in the dentition, and the temporomandibular joint, and in the airways. When we have a scenario like this one, when we have an increased overjet, class 2 relationship, and affects the aesthetics of the lips or the aesthetic of the patient, we can affect that using the motion appliance, the dentition, by correcting the position of the canine and the molar in the right place. That will create the possibility of reduce the overjet at one point before the treatment plan. We correct the aesthetics of the lips. Once we have that, sometimes the mandible will create a reposition. By reposition of the mandible, by the reposition of the mandible, we can increase the airway space because we can literally move the tongue forward, and we have a more stable TMJ position. So everything that I preach in the diagnosis, this appliance was telling me that we can do that. We can influence that with the diagnosis and make the diagnosis about those 3 structures. And then we have the ability to correct that clinically with aesthetic and beautiful results using braces or using aligners. This is an example of correcting, after correcting the class 1, using aligners and finish the aesthetics, the occlusion, and the final results of this patient. So this scenario is the one that was inspired too, you know, and maybe I was talking about the airways, TMJ, and dentition all the time, that I was thinking, you know, there is not an appliance that I can do that in the past that is giving me that satisfaction of kind of impacting everything at the same time. Definitely the Herbst appliance in that case that we used to use a lot, because I learned to use that appliance in the school a lot. So that was not giving me that. This was not necessarily giving me the stability of the occlusion immediately after the use, the stability of the temporomandibular joint, because sometimes the TMJ was positioned anteriorly and it was not stable in a stable position, and definitely we never explored the impact in the airways. So once I have the diagnostic key taken care with an appliance that is going to taking care of those structures, I can create the priority list. And then sagittal first makes sense. Sagittal first make a lot of sense, because if we correct the sagittal first, it's going to influence all of these structures. Maybe that is a good philosophy to follow. So I use motion appliance for all of my cases, class 2 and class 3, and I have unbelievable results, and I'm going to show you that. So we have to visualize the end before we start. When we talk about visualizing the end, is again, you know, the patients don't like to come to the practice. And maybe the COVID situation now is telling us that maybe we don't have to see the patients that often, but we have to do a good diagnosis and treatment plan. So we have to visualize the end before we start. We have technology now, especially dental monitoring, virtual consultations, virtual controls, okay, that we do in our practice, that allow us for the patient not to come all the time. So we have to visualize the end with these appliances and this technology, so we can offer very predictable results for this patient. For example, Imarion, it's a nice story. Actually, Imarion is a football player, very strong guy, 12-year-old patient, okay, has been teased so many years for that little gap that he has. So the gap is a combination of course, dental problem, but in addition, it has a high frame. Even the case is so easy to treat by braces or aligners, we have to be able to make a diagnosis, rule out any problems in the TMJ and airways, and start the treatment for unbelievable dental results. So the first thing that we see is the airways. Okay, I always look at the airways very closely. He has reduced airway spaces. The way that I measure that is I measure the most constricted area, and I compare with the normal or the average measurement for the patient age. Every patient grew 10 millimeters for the airway spaces. So for a 12-year-old patient, you're supposed to have the minimal cross-section area of 120 millimeters square. This patient, Marian, I'm sorry. Oh no. Okay, I'm not going to be able to maximize that. But with the Marian, we have 94. The problem is hypertrophic adenoids. Okay, the adenoids are inflamed. The problem is nothing that we are going to send the patient for an ENT and surgery. So we recognize the problem. We talk about the tonsillar hypertrophy to the patient and to the parents, and we are moving on. The second thing that we are going to diagnose and do treatment planning and make sure that we have integrity of the structures is the temporomandibular joint. The condyles, the integrity of the cortical line and the morphology of the condyles, not only in the condyles but in the temporal bone, and the position of the condyles in the glenoid fossa is something that we have to see very well before we start treatment. And the third thing that we see is the dentition. And the dentition, this patient doesn't have any impactions with the exception of the wisdom teeth, which eventually at one point they will extract. But the only thing that we have is that diastema. The diastema, some rotations. The diastema is important that we are going to be able to correct it, but we have to be able to explain the patient at the beginning that we have to do maybe a frenectomy in order to maximize the results. So we have the diagnosis and treatment plan based on those three structures. So we want to have a technology that allow us to finish the case in a steady way, in a comfortable way for the patient that is playing football. It's the football season, it was in August, quickly, okay? One thing that we explain to the patient is that he has a tooth mass discrepancy, meaning the left lateral is conic, it's called a peg lateral. So we explain to the patient that after closing the spaces, we have to rebuild that cosmetically. So we propose that in the treatment. Then we show him the progress. This is what we are going to do. We're going to see the patient before and after. This is how we are going to correct your spaces. The midlines are going to be in a nice way. It's no problem as far as the sagittal relationship in both sides. One thing that I didn't do initially, but we are going to do it in the refinement, is this little rotation of the second bicuspid, and the same thing in the top. So, but for the goal that the patient came closing the gap, we can do that very fast, very consistently, and with a good experience for the patient. Patient, before we deliver the liners, that appointment in August 12th. The aligners we used were the SLX aligners, perfectly fit. The patient was extremely happy. The patient was like, wow, this doesn't feel like I have anything. I can play football. I always want to have a mouth guard. This look, it feels like a mouth guard. Second appointment, 8 weeks after, I proposed the patient to change the trace because the changes were very easy to correct. We proposed the patient to change the trace every week. After 8 weeks, 8 trays, we have literally almost final results. The only thing that now have to concentrate is in the frenectomy and the cosmetic bonding of the lateral. So when I do the treatment sequencing in my software, I do the records, I plan for the records, I plan time for the records, I deliver the liners, I adjust the liners from 8 to 10, bringing the patient a liner number 8 to see what they have, if the patient maybe is not wearing it, maybe we're not seeing the results that we want. We spoke the patient about frenectomy and aesthetic bonding of tooth number 10, and then we took refinement records if we needed. In this case, I think the refinement records are necessary because of the rotation of those bicuspids. And again, we have plenty of time to do that. We treat the case in 4 months here, but I think we have plenty of time to do every detail possible to make this case spectacular. The second thing that we are going to talk about, the minimum touch technology and appliances, is how we influence the airway spaces. This is a okay paper. This is not the most impactful paper. The scientific method is not necessarily the best, but one thing that it shows is good. Definitely is the use of three-dimensional computed tomographic evaluation of the airways after the use of the carrier motion appliance. The good thing is the paper describes the mechanism or the understanding how we treat class 2. We use the class 2 mechanics, which is involving moving the mandible forward, but the main factor is correcting the sagittal relationship of these patients. Forward position of the mandibular arch and teeth is affected by creating more room for the tongue because of the position of the hyoid bone, causing changes in the airway dimensions. The paper describes very well how we correct the class 2 using motion appliance. The second thing that they describe is how we impact the airway spaces. Two ways to evaluate the impact of the airway spaces changes: volume and minimum cross-section area. Okay, the volume for me is very difficult because sometimes I put a landmark here and here, maybe above the palatal plane and below the epiglottis, and some people put that area in between. So volume is very difficult to measure because not necessarily all the time they are measured consistently in the same place. However, the most constricted area is something that I have to measure. Either ourselves or the computer will measure that. And these cases were not necessarily airway issue patients. The patients have 171 millimeters squared plus minus 56 millimeters to correcting to 212 plus minus 6174. That means there was an increase of 23.4% of the minimum cross-section area. For some people, 23%. For these papers, 23% was wow. For me, I'm like, okay, that is good. 23% is good, but I want to increase the airways by 100 or by doubling the amount of airway space that I have. So this article described the mechanism of the use in the carrier very well, and the impact of the airways. I can tell you that we can change the airways by using the motion appliance by a lot. So let me give you an example, and I'm going to use an example of a very elegant clinician in Phoenix, Arizona, Dr. Shipley. Dr. Shipley, again, you know, I'm using cases that I learned from him. So Dr. Shipley has a very good point in his case. When he showed me this case, like, wow, can I use this case in my presentation? So this is a unilateral class 2 with a right side class 2 relationship, canine and molar, left side class 1 molar and canine. Mild crowding in the top and bottom, midline discrepancy. Okay, how he was going to treat this case? He was going to use a motion appliance. He uses a lot the propel to expedite, to make the treatment faster, and he also overcorrect the left side. So after 3 months of using unilateral propel, he did a re-scan to deliver a correction for the upper and lower 2-to-2 using propel and using aligners. Look at the relationship of the right canine and molar. Look at the relation of the left canine and molar, which is super class 1. Now we have the spaces ready to correct and align those teeth and correct the midline and correct and finish the case faster. Then the final results from the beginning to the end took 6 months total treatment time. Look at the midline, look at the relationship of the right and the left side. The left side is a little bit molar super class 1, but the midline and the relationship and occlusion is perfect. The reason why I present this case is not because, you know, we can correct cases class 2 relationship very fast. The reason is that Dr. Shipley is very elegant and very respectful of the structure that we talk about all the time, TMJ and Norways. In this case, the TMJ, the airways were maximized. Remember, the paper said that you can increase the airways by 23%. They generalized that. I kind of like proved them wrong that we can literally increase almost 50% of the time, especially in this case, from 249 to 450. And look at how the TMJ is before and after the treatment. The TMJ, the condyles are concentrically positioned in the glenoid fossa, giving a very stable result for the retention. So again, you know, when we talk about airways, we have to analyze the surrounding structures. It's not only airways, it's how stable is the case, how we rotate the mandible forward, and how the TMJ is going to retain those results. Airways is one of the changes, but as you can see, everything changes at the same time. Second thing that I do is I spend time because of the teaching, because of the ability to have softwares and tools that I use in my practice. I use diagnostic technology to my benefit. So this is my nephew and one of my fiance's nephew, actually, which is my nephew, and he presents like this: bilateral canine class 2 myocardial increase overjet. That's one thing that we can observe in these pictures. When I do, remember when I said I create a portfolio, I create an organization of the images in one paper or many papers. So this is a summary of the case. Remember the photographs, the airways, the panoramic, and the lateral cepts and posterior anteriors and the TMJ. That summarized me in one paper all of the records. When I subtract and start to segment the information, one thing that this case is showing me that I didn't realize, but I will tell you what happened. Look at the inclination of the maxillary and mandibular incisors. Increase of the axial inclination, flaring those incisors. I'm going to give you the surprise before I tell you what happened. So because the patient has an airway issue, the patient was always trying to place the tongue forward. When you place the tongue forward, it produces this inclination or increasing inclination of the maxillary and mandibular incisors. But why that happened? Why is so inclined and maybe it has an unstable occlusion? It's because it has an excessive or large amount of tonsils and adenoids that is not going to let the patient to breathe correctly, okay? So if we diagnose that and we don't fight with the airways when we correct the sagittal relationship, that is to our benefit. So we have to do our records. This is the lateral sagittal view, and look at the minimal cross-sectional area for a patient which is 12-year-old is 30 millimeters square, supposed to be 120 millimeters square, so it's extremely reduced. And of course to the age, and this is the anterior or the posterior anterior projection, and this is the sagittal projection. This is telling us that here at the level of the tonsils, there's a lot of constriction. We can correct this case with everything that we have sagittally, but still the airways are not going to be influenced. So talking about the 23% or talking about doubling the airway spaces, nothing will change the dimensions of the airway spaces if we don't send these patients to the ENT. So I measure the inclination of the upper and lower incisors, but still I didn't want to extract in this case. And the reason is this: they extract in my mouth, upper and lower bicuspids, first bicuspid. And I think that influenced in the problems that I have for my airways today and the sleep apnea problems that I have today. So I didn't want to do the same to my nephew, the same thing that they did with me in the past. So I tried to do everything possible to not to extract it. So I create a radiology report. The radiology report again summarized everything, but at the same time that summarized everything as far as the tonsillar hypertrophy and adenoid hypertrophy and reduction of the airway spaces, it gives me a tool to interact with the ENT. When I interact with the ENT, now we have the tool for the patient to go and interact with the possibly to have a tonsillectomy, and that's what happened. And we have a summary in the results. We have a summary of the findings in the second and the third page. Look at the tonsils right here. I can explore that, but we don't have time for that. I can explore this in the volumetric data, and the tonsils are almost kissing each other. So the patient, Santiago, went to the ENT. He has some tonsillectomies. This is the situation here, and this is after the tonsillectomy. Look at the amount now. He is almost like a 300 millimeters square after the tonsillectomies. The problem is this: I correct the class 2 using emotion very proudly. He followed all of the rules because I told him that I want to use him as in my presentation. He was correcting very well the class 2. The problem was that I completely forgot about the tongue habit. Santiago was placing the tongue forward all the time. So the moment that I removed the motion appliance and I put braces, in addition that we start to have some unraveling and level and align, we start to increase the inclination of the upper and lower incisors. And the reason of that is what? The patient is still fighting, this is still positioned, because now that it's breathing correctly, it still have the habit to placing the tongue forward. So again, Luis teaching some of the classes that we have to teach the patients better tongue posture. In this case, it will make a huge difference, and I completely forgot about that. These are the superimpositions. As you can see, the superimpositions show how the tonsils were before and how they were removed. The airways increased a lot, not because of my motion appliance, but because of the combination of a good diagnosis and the surgical approach. Then I say, okay, I'm going to make a treatment plan. I'm going to see what if I make the right diagnosis and I catch these things before, because I didn't, to be honest with you. So now, using three-dimensional technology, I'm going to show you how we can treat treatment plans and how we can create options for us. So this is the situation: bilateral canine class 2. The second molars are class 2. The premolars are class 2. As you can see here, the premolar. The molar is kind of class 1, but the premolars are class 2, and the canines are class 2. The same story in the left side. Okay, so what happens if we do a motion appliance? We have the increased overjet. One thing that we have to do with the motion, or we do with the motion, is correct the rotation of the molar. Okay, I'm going to do one by one. This doesn't happen, everything happens together. So we correct the rotation of the molar, we create the space, and that is going to give us a space to distalize and to move everything back. Okay, so once we correct the relationship of the rotations of the molars, so now, not one by one, but in mass, we are going to be able to distalize premolars and canines into a class 1 relationship. Once I do that, I have the correction of the problem that I have. The only thing that I don't have here in this case is, or I didn't take into account, was the inclination or the axial inclination of the maxillary and mandibular incisors because of the habit. So if I correct this case today, I am going to tell the patient to, correct the habit. We are going to train the tongue, and we're going to have better results. However, we still have inclination of the lower incisors. So how we are going to correct that if we don't have a space? We have crowding, and we don't have a space. Well, this is how we do it. After the correction, great, we correct, we place the patient in class 1. Great, we spend time doing diagnosis and treatment plan rather than the patient being in the office trying things, okay? So this is a good way for us to not fail in the mouth, but kind of make assumptions in the computer. So this technology is amazing. In this simulation, maybe I should spread more the central and the lateral incisors, the maxillary incisors, but still, as you can see, the inclination of the lower incisors and the maxillary incisors, it was too much, in my opinion, okay? So a lot of people say, oh, I will extract in that case. But the other solution, the alternative for this solution will be to use the motion appliance for class 3 correction. When I do that, I will increase the class 2 and make the class 2 bigger. So you see that the molar is class 1. But if I do the alternative, this is what I plan to do. So I distalize the canines and the lower molars using the class 3 motion appliance. Okay. I make the case or the class 2 worse. Okay. And when I distalize that, and I make the case more class 2, now I have a space to correct that severe axial inclination that I have for the lower incisors. And that way, I correct the axial inclination of the lower incisors, then I can use the motion appliance to correct the class 2 relationship and the axial inclination of the maxillary incisors. So again, this is a learning process. You know, the technology that we have today, and the reason why I brought this case is this. It's not because I want to show you how I failed, it's I want to show you how I learn. I learn from my cases using the technology that we have at our disposition. These are called anatomy models, and from Anatomash, I use it all the time when I see a difficult case, and also when I want to teach some or make a point of some things that I have, especially with impacted canines and everything. In this case, it will teach me the alternative, but unfortunately, that patient was not treated that way. And if I do it again, I do it this way. The last case that I want to show you is, of course, a lot of people want to see class 3, because remember, I said, you know, Luis inspired me to do correct class 2, class 1, class 3s. So let's talk about class 3. The case that I want to show you is a motion appliance class 3 using SLX braces and finishing and detailing the case with the SLX aligners. This is what we call a hybrid case. And the reason why this case became a hybrid case, it was because of COVID. The patient was a little poor compliant, you know, the patient was like not necessarily the best patient. And I want to avoid to let the patient go for 4 or 5 or 6 months, you know, and maybe lose everything that I did in the past. So let me present the case to you, okay? She was class 2 relationship. Again, I used the anatomy models. She was what we call posturing, that bite, so making kind of like a more worse than it was. So the patient has the tendency to move the mandible forward. Dual bite is not necessarily that way the way that the patient bites. The reason why she bites like that is because she wants to touch the posterior teeth, put the posterior teeth together. So I use the records using the example of Dr. Shipley and using the example of analyzing temporomandibular joint dentition and airways. I, of course, put everything together. As you can see, the condyles are positioned anteriorly and inferiorly in relation to the center of the glenoid fossa. That means that that bite is posture. Okay, that bite is not necessarily the correct bite. Maybe when I manipulate the patient literally was edge to edge, but the patient will always bite like that. The patient didn't have any issues in the airway spaces. Not really compliant the first 2 months, is like, oh my God, what I'm getting into, okay? But after 5 months, the patient saw a change. It's like, oh my God, I can bite my teeth and I can have my anterior teeth in a better relationship. So the patient helped me. So there is a little extrusion of the canines. There is a little space that I use for my benefit, distal of the lower lateral incisors. One thing that I do, if I didn't do, but I will do in the future, is I take into account the transverse dimension and I use an expander as an anchor to do the class 3 correction for 1 month. So in that case, it will, for my benefit, to use an expander, but I didn't use it. In this case, I'm telling you, if I use the maxillary expander, I think the case will be much better. Progress, 12 months. And the problem that I have is I couldn't close the space between the centrals because we need to do a frenectomy. Of course, a frenectomy session today, but the results were incredible. the results were amazing. The midlines are not necessarily on at that time, but the results were incredible. The results after 12 months, it was like, wow, this case is good. I was extremely happy. I was like proud that I took those courses to learn how to correct my cases using the motion appliance. And this is one of those cases that I want to show a lot of people. Then we have after the frenectomy, 15 months. You see that for the 3 months, I didn't do much. The only thing that I did was the frenectomy, and I closed those gaps. But I didn't do that much. I didn't want to go into another session of time with the patient that was going to disappear after February, and I don't know what is going to happen. I didn't want to leave the patient with this finishing. So I decided to remove the braces and correct the little details that I had using aligners, minimal touch technology and appliances. Final debonding, great case. I'm proud of my case, so I think it was good. I think patient was, especially patient was happy. Patient was ecstatic. We have unbelievable results. We have a wide arch. We control the spaces. We have a class 1 relationship. We have midline relationship. It's a little bit of changes that we need to correct. So this is a good result. So the problem with this is the midline was not necessarily perfect, and I'm picky, and I want to correct these little details by using the aligners if I need to. So what I did was, this is class 1 relationship. I did a treatment plan with the SLX aligners. I need to have better settlement and a better relationship in the right side. This is the occlusion, nice occlusion. I have to do a little bit of IPR. There's something that I was not going to see if I don't take digital records. So this is how I was going to correct. This is how I'm going to detail this case. So minimal touch technology, minimal touch appliances. There's only 10 aligners, and I think we're going to have great results. So this is at the time that we have the aligners using the staging session. So as you can see, we can correct the midlines. These little changes, but I went to do that because of the COVID, and I think that's what we can do. As you can see, we must have some IPR, and we play with this IPR. And if I didn't do the digital records, I was not going to see where I need to do IPR to correct this and to make it perfect. In my opinion, I make the patient much better, and I finish the case spectacular. So I'm very proud of this case. I use the technology to my hands, which is the motion appliance, the SLX, which in this case, they did amazing, and we finished with aligners. So this is a summary of a minimal touch technology and appliances which are going to be applied for comprehensive treatments. As a summary, I use diagnosis as the foundation of my treatment plans, and I command you to do that. And I'm going to thank you, and I think we're going to turn to Mary. And thank you very much. Hello from Indianapolis, and thank you very much. Have a great day.
So thank you for your presentation. I was taking notes along the way and soaking in the information. I do have some questions for you, so I'll go ahead and jump in. That works?
Definitely, thank you.
So the first one, yes, of course, and I think you did mention this, but just to clarify, do you take a CBCT on all of your patients?
Yes, it's a very good question, because I want to see all of the maxillofacial structures in 3 dimensions. I have to maximize my diagnosis using the 3D technology. So the only way that I'm going to be able to do that is if I use a cone beam. No other technique in dentistry allow me to do that. So I use a cone beam with all of my cases. And again, when a patient comes and say, I don't want cone beam because of the radiation, I said, there's no way that I can treat you. But the reason why I kind of justify that is because I subtract all of the information and literally squeeze every detail that I can from my cone beam. As you can see, especially I'm a radiologist, I do reports, I do anatomy models, I do everything. And so I kind of squish everything that I can from that volumetric data that allow me to use it in all of my patients.
And what is your cone beam of preference?
I have an icon. I use an icon for forever, and that is the combine of my choice. If I have to buy another combine, I will buy the same. I mean, second icon, and I'm going to hold in mind the one that I have before I buy a new one, because it's like the best investment that I have in my practice. But if I have to buy one, and there's other reason why I use ICAD as well. And again, I don't have anything with ICAD and anything that pay me anything. But the reason why I use ICAD is because they have so many machines. They have done all of the research. Everybody likes that. So it's like having something that everybody has that is proven to be the best one. So there's no reason why I want to explore with a different company.
Gotcha. Okay, thank you. Thank you. So you're offering remote monitoring for your patients, and you're doing that also with motion and aligners? Yes?
Yes, correct. The, two ways to do the monitoring. And I use in some patients dental monitoring, which is a tool that allow me to put a little bit of technology in the monitoring, because dental monitoring uses some artificial intelligence to make decisions, to make recommendations when to change the aligners, or when to move to a different, more elastic or less elastic, so you are ready for the correction of the motion. But it will allow me to make decisions without the patient come. And the second way that I monitor and I do virtual consultations is using using the GoToMeeting. I have a GoToMeeting in my homepage, and this consultation with Dr. Eraso. And the way that we do that is initial consultation. So in that way, I filter a lot of patients that really are shopping and to see the best decision. And the only thing that they want to ask is price. They are not really interested in the process. So you know that, but people interested are really asking the right questions, and we are able to see some video shots of what kind of information they have. And the second is when the patient is using motion, for example, and I don't want the patients to come back all the time. I usually see the patients every month, but if they have enough rubber bands and they can shoot me a picture and send it to my homepage, or they can do a virtual consultation with me, I can tell them, you are ready, come and just go ahead and remove and put braces or take impression for aligners, or go ahead and keep using those class 2 for another month or two.
Okay, as long as they're consistent with their elastics, right? So are you seeing the same number of patients from pre-COVID to where we are now? I won't say post-COVID, but where we are now, scheduled and affected now that you're back in your practice, and how are things now with that?
Yeah, we always want to see more patients, but to be honest with you, what we are doing is we are being more efficient in the way that we're seeing our patients. I think we are seeing more patients, to be honest with you, because there's a lot of interest lately. I think there's people are saving money for real things rather than spending money in things that they're not supposed to, like in the past. Now they save money as like they are ready to have braces, and they come and they have money.
Hearing that, yes. People had a lot of downtime to think about what was important to them, and then
we see more real interest in braces and real patients that come to our practice. But the most interesting thing is because we don't want to be in the office 5 days a week or 6 days a week. What I do is I maximize my schedule, making long days rather than short days, like 5 short days. I would rather do 2 or 3 long days and don't work the other time. It doesn't mean that I don't work, Mary. I read all the time. I do radiology interpretation all the time. So
I know you have multiple.
For that too.
I know your energy. You shift it purposefully. So, in your view, how long should a patient wear each set of trays before they move to the next step?
It's a very interesting question. Depends. Okay, and ideally, because we are not supposed to do things in a rush, ideally we're supposed to use the change the trays every 2 weeks. Okay, and I think that is a good goal. Okay, But if you want to finish fast and if you want to change the trays faster, 10 days is a good compromise. But if you really want to finish faster, like Dr. Ship does, you have to apply different technologies like Propel and do some kind of like a stimulation of the bone to make difficult changes, faster changes. The problem with that is the faster that we do changes, in my opinion, maybe it have an impact in the stability of the case. So sometimes there's no need to rush when you are going to affect the stability and the retention of the case. So my opinion, 10 days is my goal. 2 weeks, I always tell the patient wait 2 weeks unless they have an agenda. Because
Okay.
20, like if I do 10 aligners, it's 20 weeks, it's nothing. If I do 20 aligners, it's 40 weeks. Everything less than a year is okay.
Okay, thank you, thank you.
But the other thing, Mary, is the other thing is this. When I do my treatment plan, and you're going to see my lecture on aligners, when you do a treatment plan and you see that your treatments are 30, 35, 40 aligners, that means something there. Okay, so that will again tell me that maybe the case is not going to be successful if you do only aligners. So that will give me the ability to think about motion appliance to correct sagittal, or maybe to do kind of like a hybrid case, do braces first and then aligners. But more than 20, I think is too much, in my opinion.
Okay, thank you for that, for efficiency. I know that topic of this symposium is minimal touch orthodontics and creating efficiencies and safety. So I think we'll have time for one more question.
Just one more, Mary.
Yes, I think one more. I have more, but I'll pick one. Should the patient be in a class 1 or a super class 1 before starting aligners?
Again, it's a very, the key is, it goes both ways, okay? The key is to provide the patient a good stability, meaning if you leave the patient a good set of retainers, or like A6 retainers after you finish your aligners, great. So you can print that in your practice, okay? So if you can do that, great. And the other thing is, and it's very difficult because every company is suffering returning your trays fast enough so you don't suffer with the relapse, okay? So if the trays are delivered in 3 or 4 weeks, great, you can have an Essex you can retain. But if the case is going to take longer from the companies or the treatment plan or whatever happens, okay, and it's better to overcorrect. And Luis is going to say that it's better to overcorrect those cases and kind of expecting those changes. But ideally, it's a team. You know, when you are efficient and your mechanics, you should be able to have a plan to retain the case in between. So that should be in your plan. And so don't blame the manufacturers that, oh, these guys are taking too long. No, you have to, you don't care. You are retaining the case. The patient should not complain. Nothing is happening, and the patient is having a retention with an Essex, for example. So it takes both ways. It takes good planning. It takes a good conversation, a good team effort with your engineers that are doing your treatments, and of course, ideally, the commitment of the company to have the cases faster.
Thank you.